As I was introduced, I'm a hepatologist at the gastro unit at Hvidovre Hospital. And actually often I like to refer myself as a hepatocrinologist because I worked within the fields of endocrinology and hepatocrinology for years now. And I was told just when I came here, which was very nice, that I was among friends. And a lot of you are going to be or are diabetologists and hepatologists and diabetologists. We're going to meet each other in the future because of this condition. So I hope you will listen carefully. I'm only the only one in this session, the only one to talk about liver diseases. So I look for some help among friends, and one of my friends, what I really like, is the Belgian detective Hercule Poirot. I don't know if you know that guy, but let's see if I can make this work. This is Hercule Poirot, and he will set the scene for the next 20-25 minutes of liver disease.
Are you feeling better, Hastings?
Yes. Yes, I am, as a matter of fact. Takes the pressure off the pancreas, you see.
Ah, the pancreas is nothing. Of the digestive organs, the liver is the key. Look after the liver, and life will take care of itself.
Yes. Look after it, and life will take care of itself. So I hope I didn't offend anyone. On that note, I will go to my talk. So the first slide here is what I'm going to talk about. I will take you through the landscape of NAFLD in a very clinical setting. Talk about what it is. I will go through Fibroscan, non-invasive biomarkers. I will also, during my journey here, invite you into my clinic with some little video clips that I borrowed. You can see what it is we do. And there is a little bit about treatment and some take-home messages. So we know that around 20 to 25% of the world's populations has some kind of fatty liver or simple steatosis. Around 15 to 30% of these patients will progress into a non-alcoholic steatohepatitis, which is characterized by ballooning cells and inflammation in the liver. So if this allows to be continued for years, patient can develop fibrosis, which is divided into 1, 2, 3, 4, which is characterized, we also call it cirrhosis. Both NASH and this fibrosis is histological score. So right now, as it is, it demands a liver biopsy to diagnose these patients. So just to get back, around 15 to 20% of the people with NASH with over years develop some kind of cirrhosis. We estimate that it takes around 7 years to go from one fibrosis stage to another. It's a very slow progressing disease. There are now reports, and also we are aware of some fast progressors where the progression is half, so it's about 3 years. But we have no clinical tools or no real good tools to find out who that is yet. We just see them in the clinic. Cirrhosis, not a good disease. One half or 1/3 will decompensate and die of liver-related causes. Yes, I think that was kind of that is the spectrum of NAFLD here. So this is very prevalent in your diabetes population, as I will come back to, and you can say, is it important to diagnose? Is it important to find these patients among your population with diabetes? Yeah. 5% will get HCC, which is hepatocellular carcinoma, which is also with a bad prognosis. So you can say that NAFLD is actually a potential malignant disease. And you can also here get NAFLD, you can get hepatocellular carcinoma in a non-cirrhotic liver. About 20% of the patients get HCC in a non-cirrhotic liver, but it's mostly prevalent in cirrhosis. Here's my next slide. So, why do we have to diagnose patients? we need to identify patients with a bad prognosis and who could be eligible for treatment. And treatment, we can talk about that later, because right now we don't really have any pharmacological treatment, but we have another treatment that is very well documented. I will come back to that. So is it NASH? Is it fibrosis? Is it fatty liver? What is it that we're looking for? What determines the course and the prognosis of these patients? And here I come to one of the first differences, I think, between hepatologists and diabetologists. Diabetologists like to talk about NASH and fatty liver. As a hepatologist, I really look for fibrosis. So fibrosis is key in these patients, because we know that fibrosis is associated with increased mortality. This is a Kaplan-Meier survival estimate plot we have here, where we have time out here and proportion of a live patient here. And here you can see the different fibrosis stages. So F1, that would be NASH without any fibrosis. I mean, F1 and F0, they kind of do well as the normal population. But if you already go to F2, F3, F4, which is cirrhosis, you can see an increased mortality. So as a hepatologist, I would like to find the one with fibrosis. So again, to get back to your population, get back to the endocrinologist in me, I try to illustrate how many of your patients, if you are endocrinologists, who have some kind of NAV-related condition. So imagine that you have a waiting room in your diabetes clinic. So there are 100 patients in this waiting room. It's a big waiting room, and you had a very long day. So overall, 55 of your patients would have some kind of NAFLD, the whole spectrum of NAFLD. Around 37 of your patients will have NASH. 17 patients will have significant fibrosis. Significant fibrosis is defined as more than F2 according to the survival plot you saw before. That's the one we have to find. And one of your patients will have cirrhosis, and they have an annual incidence of hepatocellular carcinoma between 2 and 12 yearly. So these are the populations you have. You have, and that's a type 2 population. The risks increases with these risk factors, as you probably know, like central obesity, mixed hypervolemia, hypertension. Increasing age is also a risk factor, because it's a slow progressing disease. The higher age, the more risk of getting advanced fibrosis stage. Insulin resistance. Insulin resistance is probably the driver of this disease. There are also genetics that you can't do anything about. The best known is this one, PNPLA3, which is known to increase the risk of steatosis in patients. Yeah. So normally, as a hepatologist, and also I think every other doctor, when we want to diagnose patients with a liver disease, we rely on ALT. And I think, that's also what the patients here, that's what a lot of my colleagues, they take ALT and it's normal, and then they think, okay, everything is fine. So we know that in the entire spectrum of NAFLD, ALT can be beneath the normal level. So just to say, it's not very good. To specify more, ALT is normal in 20 to 50% of patients with NAFLD. That's again the whole spectrum. More than 35% of patients with NASH and all the degrees of fibrosis, including cirrhosis, have normal levels of ALT. I mean, for hepatologists, we have always known that cirrhotic patients can have normal ALT because they have no, liver cells to get this response. But on the same time, you can see elevated LLT in more than 60% of patients with simple steatosis. So what do we do? What did the clever detective do? How does he try to find the patient with significant fibrosis? Well, There are a lot of non-invasive score, both commercial and non-commercial, on the market. I will start with this one, FIB4. I don't know if you're familiar with the FIB4. It's the one we use in our clinic. It's cheap. It's fairly good. There is a lot of good evidence behind this. It's just a simple score. You just take people's age, you take AST, which is another liver enzyme, you take platelets, and you take ALT, and then you get a number. This test, as a lot of the tests, is very good for ruling out significant fibrosis, and that can be a big advantage in big populations like the diabetic population, where you have moderate prevalence. So if the ALT if the FIB4 cutoff is made here 1.45, you can expect a negative predictive value around 90%. So it's very good to rule out fibrosis. So there's a big portion of patients we just can treat their diabetes. That goes for this age group. If you increase age, then the cutoff should be 2.0, where it have the same negative predictive value. It's not very good at the young population. It's not very good at the minus 35-year-old. So, yeah, this is another non-invasive score that's used. There are a lot of diabetologists who like this because it encompasses more valuables. And I highlighted those valuables extra with the red. It's BMI, it's glucose status, and it's albumin. Here, it's more difficult to calculate. Often you can go into this website. You can calculate easily by putting in the different valuables. Here, with a cutoff of minus 1.455, you have a negative predictive value around the FIB4. Now, the reason we use FIB4 in our clinic is that you can get it just by normal blood samples. We have an agreement with our lab, and I think it goes for other labs, especially here in Copenhagen, that we can order it and we can get a number. So we don't need to talk to the patients. We don't need to ask them if you have diabetes. We don't. So we can just order it in our lab. And we can get it out. So that's very useful for us. You will still have a lot of patients that are left in the gray zone that will say you cannot rule out significant fibrosis. So there are other markets, other non-invasive fibrosis markers and inflammation markers on the market. But they don't, until now there's a lot of research, and we still do a lot of research in these, but they don't perform much better than the really, really simple ones that we already use. There are markers of inflammation. CK18 has been on the market for years. It's not really reached the clinic yet. Then there are direct fibrosis markers that measures components of fibrogenesis or fibrinolysis. The ELF test, which is very used in the UK. I know it's in their national guidelines. Fibrotest Pro C3 is also has also been used. And then, of course, the holy grail of NAFL research is new biomarkers. We really need a biomarker that are available, who can diagnose NAFLD and NASH and fibrosis all in stages very accurate. We don't have that, so we still rely on histology. So that was the non-invasive biomarkers. I will try to go into to diagnostic imaging of NAFLD and fibrosis, if you can. It's pretty simple to look for steatosis. You can use the Fibroscan that I'll come back to later with the cap, and I'll also come back to that later. But that is a measurement of fat in the liver. It's not very good yet. We don't use it that much, but it's there. You can do an abdominal ultrasound. I do abdominal ultrasound myself of my patients. And you need around 20 to 30% fat involvation in the liver to see it like so on the ultrasound. The definition of fatty liver is more than 5%, so you will miss some. So even if you have had patients that comes back with a normal ultrasound, they can still have NAFLD and also NASH and fibrosis. It's not always seen. So if you want to do it really advanced, you can do MR spectroscopy, which measures pretty exact the amount of fat, only fat in the liver. So when we look for fibrosis here, we use the Fibroscan with elastography, where it measures the stiffness of the liver, and I will get back to that later. Then you can also, there are different techniques. You can also do it with ultrasound, and you could do it with the MR. Yeah. So now I promised you a sneak peek into my liver clinic, and I borrowed this from a course made by University of, I promise to say this, it's a very good course. I will make some more publications later. It's a course on NAFLD, and this is me doing the ultrasound and the Fibroscan.
Ultrasound of the liver plays an important role in the diagnosis and management of chronic liver disease. It's able to identify NAFLD when the degree of steatosis is about 20% or more. The Fibroscan is a specialized ultrasound that measures fibrosis and steatosis. The scan measures the velocity of a vibration wave, also known as a shear wave. The degree of hepatic fibrosis can be inferred from the values which are expressed in kilopascals. The degree of steatosis is expressed by the continuous attenuation parameter, or CAP value.
That was the CAP value that I talked about. Is this used in your clinics? Yeah, good. And it's nurses who do it? Or is it you? Okay, well. This is a Fibroscan. It's very effective of different reasons. Here you can see the probe, and you can see the shear wave coming in here, and you get your results back like so. The advantages of this Fibroscan is that it's really quick and it's really painless. It takes about 5 to 10 minutes. It can be done by trained nurses, which makes the cost even lower. The equipment itself is pretty expensive, but when you have it, it works really well. It's risk-free. It reduces the need for liver biopsy. We are also using it for monitoring patients, not only patients with non-alcoholic fatty liver disease, but also patients with different autoimmune hepatitis and other liver diseases. It also has some disadvantages. So we can have difficulties with severe obese patients. The companies have developed this XL probe, which makes the success rate higher. And what's determined the success rate is the amount of fat here between the subcutaneous fat between the skin and the liver. That's really what makes the difference. Fibroscan requires fasting. And Fibroscan can be falsely high, falsely elevated, the stiffness of the liver, especially if you have acute inflammation in the liver, if you have ascites, cholestasis, and congestive heart disease. And you can see, and it's the same. It's the same for fasting. When you eat a meal, then you have a high blood flow from the portal vein up to the liver, and you get false high results. Yeah. So we often do that we combine the Fibroscan and the FIB4 in our clinic to raise the negative predictive values. So the cutoff for Fibroscan is around 6.5 to 7.9 to rule out significant fibrosis. Again, you have a really good high negative predictive value of 90 to rule out significant fibrosis. And this is by far the best indication for Fibroscan is to rule out significant fibrosis. It's also pretty good at ruling in to detect cirrhosis with a cutoff value here about 13 to 15%. But you will have a gray zone in the middle where you really don't know if they have if they don't have fibrosis, if they can have F3 fibrosis, so that can be really, really difficult. Yeah. So this was a little bit about the Fibroscan. Some clinics have it in the diabetes clinic, some don't. I mean, I think in the future it will be something that will be done in the primary sector, so it won't even go to the hospitals, because there will be a lot of patients who will be screened. Maybe it's a dangerous word, but will be screened for NAFLD. So this is just me the other Friday. I did a Fibroscan just to show you what I did. So this is just a screenshot, or I took it with my phone actually, just to illustrate that here you can see, I don't know if you can see it, but here you can see liver tissue, and here you can see the kidney, and that's how we diagnose fibrosis. You can see there is a color gray difference here, so the liver tissue is much brighter and lighter than the kidney. So for me, that's an indication of some kind of there could be a kind of inflammation or fatty liver. And again, when you come to this stage, you will have around 20 to 30% of fat in your liver. Here we have the liver stiffness parameter. This is 4.3, so for me it's a normal scan, and this is the CAP, and the CAP is very high here. It's about grade 3 steatosis, and that would be like 90% of steatosis. Yeah. So this is the modality as I have as a hepatologist. I have one more, which is the liver biopsy, and that is not something that you are going to do, except if you're a hepatologist. But maybe you have some patients that you would consider referring to a hepatologist, either for liver biopsy or for assessment. And that's still difficult, who to send to us, who to evaluate. I try to speculate a little bit, not speculate, but try to give you some hints to who to refer to us and why it can be important. So first of all, and that goes especially for patients with elevated ALT. There are some who has elevated ALT for a long time. To eliminate what I call the usual suspects. The usual suspects in my fields are viral hepatitis, it's autoimmune liver diseases, it's drug-induced liver injury, and it's also some rare genetic disease that we always screen for. And in my group, we do a lot of liver biopsies because we also do them because of research, and sometimes we really get surprises. We have a patient that we think just have steatosis and maybe have a little ALT elevation, and we find autoimmune hepatitis and other things. So we have had some surprises. So liver biopsy is also a very good diagnostic tool if we are in doubt of what this patient is, the diagnosis of this patient. Yeah, so we try to select patients eligible for liver biopsy. We also follow up patients with significant fibrosis. That was the F2 and up. Right now, we see them once a year with the FIB4 and the Fibroscan. That is what we do. Yeah. So again, who to select for liver biopsy? Well, if you have a Fibroscan in the gray zone, I mean, if you can't rule out significant fibrosis, I would tend to do a liver biopsy. I will take into account risk factors, all the risk factors, diabetes, obesity, hyperlipidemia, and all these risk factors, and also age, because this is a very slow progressing disease. And if you have an 85-year-old that might have F2, F3 fibrosis, maybe not. Yeah, let's go back to my liver clinic. This is me doing a liver biopsy. So I've done an ultrasound. I found the liver capsule. This is a McGuiney needle, which, yeah, so so you have a little, yeah, there's a little talk here. So you make,
Alt, hvad du kan.
You ask
Hold
the
vejret
patients
bunden
to
der.
breathe out, you do a vacuum, and
prøve.
then you take the liver
Sådan.
biopsy. There it is. So it's very quick. It's not always painless, but most of the time, 50 to 20% of our patients have some kind of pain that cannot be dealt with normal paracetamol. They need morphine. Around 1 of 10,000 people, they die. So you have to be careful when you select people for a liver biopsy. It has to be said in that 1 of the 10,000 people who die, a lot of them are patients where you want to diagnose cancer. They're sick anyway. But we have to keep that in mind when we do our liver biopsy. 1 out of maybe 10,000 they die. So. Yeah, this is the little liver biopsy we get out. This is actually a very fatty liver biopsy. You can see that it's all white and fatty. Maybe you can't, but I can see that. Yeah. That was another sneak peek into my liver clinic. So what do we do to the patients? What kind of treatments can we offer to these patients? Well, we have a very, very, very good treatment called lifestyle intervention. With the diet and exercise. And as I tell my patients, you don't need to be thin and have a BMI of 30 or 22. If you lose around 5 to 10% of your fat, you will already you can get rid of it reduces fat infiltration and inflammation and fibrosis. It's very difficult. It's very, very difficult, as you know, and I think you have a talk about obesity later, but it's almost, some can do it, but a lot of them can't. There are a selected group that we treat pharmacologically, and right now there are no official options, so everything here would be off-label. What is in pipeline is GLP-1 receptor agonist for obvious reasons. We can always discuss if it's a secondary effect to weight loss or it's a direct effect on the liver cells. There are FXR antagonists, which is obeticholic acids. Right now it's used for primary biliary cirrhosis, but it probably also have a very good effect in these patients. And the holy grail in hepatology is to find some kind of anti-fibrotic compound. We don't really have that, and this might be some of the first. There are others, SGL2 inhibitors, elafibranor, Armcool, senoxinib. There are a whole bunch of people in drugs in pipelines for treatment. Yeah. Some just short take-home messages. NAFL is very, very common in the diabetes clinic. Fibrosis is key, and it needs a liver biopsy to diagnose. Fibroscan and the non-invasive markers of fibrosis scores are very effective to rule out significant fibrosis. That's their strongest for them. So high-risk patients where non-invasive markers of fibrosis, they fail, talk to your local hepatologist or refer to your local hepatologist for an assessment, and we'll see what we can do. And I mean, treatment is management of risk factors and weight loss. That's really the most important thing. So take care of your liver, and life will take care of itself. Hercule Poirot.
I have a question from the online chat from Biasolo Natalie, who asked, what are the criteria for a liver biopsy?
The criteria for a liver biopsy is an assessment by your local hepatologist. There are a lot of guidelines, and if you read the guidelines, it's very vague. But I think the consensus is if you can rule out significant fibrosis by the parameters I showed you, don't do liver biopsy. If you have a patient that has in between from 8 to 15 in Fibroscan, is not 80 years old, has a lot of risk factors, I will recommend a liver biopsy. Sometimes we also do liver biopsy, and we have another, we can also do liver biopsy from within the portal vein, where we also can get a pressure above. If we suspect cirrhosis, we do another technique where we can do venous pressure, and that's So, and there we also take a liver biopsy. So sometimes we do it even though we suspect that the patient has cirrhosis, but we do it for other reasons. So I think that's the difficult short answer. That's why we need each other, I think, to select these patients.